things. The assessing of severity is very important for us because as doctors we have so many patients coming to us with reports of HPSAG positive. What should we do? And most of the patients won't be having any jaundice. So probably we are having either a latent infection, that is just infection without any liver involvement, or a chronic hepatitis. And why we need to actually treat these patients is that these patients tend to develop cirrhosis and hepatocellular carcinoma. So with these two basic aims, we want to treat these patients. So this is my outline of presentation. So as you all know, just a brief thing, there are so many causes for liver injury, apart from viruses, alcohol, drugs, and off late we see this non-alcoholic fatty liver disease. That is, a lot of reports come to us with fatty liver. So we have two types of injuries. As we all know, it's an acute injury. It produces jaundice and acute hepatitis. And around 1 to 2% patients land in acute liver failure and they die. And regarding chronic injury, they present as chronic hepatitis, which is asymptomatic, and where we are afraid that these patients might be having chronic inflammation and fibrosis slowly. So these are the two types of injuries for the students sitting back. So inflammation is basically nothing but there is some amount of destruction of liver cells by the viruses. So this tends to impair the liver function. So this is for students, how actually it progresses. Normal liver, initial inflammation, and then slowly the advance of fibrosis and lastly the cirrhosis. The metavir fibrostasis is basically histological staging, which we use when we don't have any clue regarding the fibrosis. So this is the common presentation of all the viral hepatitis, acute and chronic. Most commonly, hepatitis A, E, B can present to us as acute hepatitis, that is fever and jaundice. And chronic viral hepatitis, it is the blood-borne viruses, hepatitis B and C. They produce chronic viral hepatitis, and viral hepatitis D is there, but usually this is working along with hepatitis B. If there is no B, hepatitis D cannot injure the lung. So chronic hepatitis is caused by B, C and D. So just a brief word about acute viral hepatitis. Remember that this is any inflammation or fever which is persisting less than 6 months. We take it as acute hepatitis. So usually the duration is 4 to 6 weeks. Just like any viral infection, there will be 3 phases: prodrome, an icteric phase, and convalescence phase. Most of the hepatitis A and E and some forms of hepatitis B, which is acquired in adult life, they have this acute hepatitis B presentation. So these are the common investigations we do when the patient comes to us with fever and jaundice. Regarding the liver, we see the bilirubin, the liver enzymes, ALT, AST and alkaline phosphatase, and prothrombin time for the liver functioning status. Regarding the viral serology, we do the IgM and Ig for hepatitis A and E, and its surface antigen for hepatitis B, as well as IgM for anti-core antigen. And of course, we sometimes do an ultrasound if we think there is a biliary obstruction. So just a point, for all kinds of acute viral hepatitis, usually there is no treatment. It is symptomatic. Most of the time they recover, only 1% or 2% they land in severe forms of the disease. So we give all the supportive measures. Usually nutrition should be maintained, and there is no rule for hepatoprotective drugs and antiviral drugs. Please remember this. Only in hepatitis B, we sometimes give antivirals. That is, when the patient goes to severe fulminant hepatic failure, there is a role for antivirals there. That is the only indication where we give antivirals in acute hepatitis B. Otherwise, we don't give any antivirals. So, this is a summary of acute viral hepatitis. First, make a firm diagnosis, identify the cause, and then just see for the progression of the disease. by using prothrombin time, which is very important. And rest of the thing is only symptomatic. Now let us go to chronic viral hepatitis. We know that it is caused by chronic inflammation, that is, there is a slow injury to the liver, which it heals with fibrosis. This fibrosis tends to produce cirrhosis. So any inflammation of the liver persisting for more than 6 months, we term it as chronic hepatitis. Usually there won't be any jaundice. So it is in this condition where people come to us with HPSAG positive reports or anti-HCV positive reports. Now we have to assess them. So the assessment can be done either by checking the liver enzymes or the fibrosis status. So how do we do it? In fact, in lab also we can see whether it is an acute hepatitis or not. Usually jaundice is there and marked elevation, that is the AST and ALT is more than 15 times of the normal times. Then probably we are dealing with a acute hepatitis. In chronic hepatitis, the enzyme rise will be very less, just around 3 to 4 times. So this is how actually we can do a biochemically also that this is probably we are dealing with a chronic hepatitis. So just remember that acute hepatitis is mostly symptomatic and chronic hepatitis is asymptomatic. So what are the other symptoms? Usually patient might have general malaise, weight loss, low-grade fever, and abdominal fullness. When the slowly cirrhosis sets in, he can have ascites, so there will be abdominal distension. Sometimes there can be pain because of the distension or fluid accumulation. But remember that none of the symptoms are specific. So this is how it is. Like this, the patients presents to us with cirrhosis, they can present with ascites or with the complications, that is portal hypertension bleeds, like esophageal varices or gastric varices or liver cancer also sometimes. So they can present with the complications. So we have to be very careful. So this is about the chronic viral hepatitis. So usually patients are asymptomatic or they can present to us with signs of liver failure or portal hypertension, and sometimes there will be development of decompensation of the persisting liver disease. So first, let us see how hepatitis C can be managed. Remember, hepatitis C is a very slow disease. Usually, all these blood-borne diseases, either they come through the vertical transmission from mother to child, or in adult stages from needle prick injury or unsafe sexual practices, or when hemodialysis is there, a lot of blood transfusions are there. This is a way where they contract the disease. And hepatitis C is a very slow disease. Usually it takes around 20 to 40 years to develop liver cirrhosis. That's why people are not aware. So we have to be very careful in diagnosis of hepatitis C. And usually hepatitis C, they present with cirrhosis when we see the patient. We rarely see them in chronic hepatitis C. Now of late in the last 10 years we are able to pick up these cases early because there is a good surveillance now in blood banks and also in some before surgeries we do for hepatitis C. This hepatitis C is first discovered in 2000 itself. Of all the viruses, this is the latest virus that is discovered, and also this is the first virus to be, I think probably will be eradicated. So this is what happened. First it was named as non-A, non-B hepatitis because at that time, apart from A and B, we don't know what is these viruses which are detecting and causing disease. Then slowly they detected in the blood banks, then they went to the sequencing of the virus. Then in 2000, they came to know that this is another separate virus which is causing this kind of disease. So the good thing is now we have limited therapy for this virus. Initially 5 years ago, we were treating this virus with injectables, very difficult to treat because we are treating with interferons and all those things, very costly. And also the response is only 70 to 80%. Now we have antiviral drugs which are almost getting a cure for almost 98% in just 3 months to 6 months therapy. So this is the best part of hepatitis C management, which has almost changed our concept of disease in hepatitis C, right? So when you come across hepatitis C acute infection, usually acute hepatitis C is very difficult to diagnose unless we know the status, because this is usually seen in dialysis patients, because once they come to the dialysis, initially they are negative. Then after 2-3 dialysis sessions, they become positive. Probably either they are acquiring in the blood transfusion set or through the dialyzer, we don't know. Then they become positive. So these are the patients who develop little jaundice and malaise. So these patients usually initially when interference were there, it was very difficult for us to treat. Now we are able to treat these patients with again the same antivirals. But we have to wait for 1 or 2 months before we start the treatment for acute hepatitis C. Once the disease is confirmed, it's persisting for more than 6 months. Here we have to treat the patient. So some definitions. This is actually from the control program. What is active? That is, still the virus is present in the host. Resolved means no virus in the host. That is, the immune system has cleared the infection. And what is the lab-based definition? That is, active means serum RNA positive. Resolved means RNA negative. It's not the antibodies we see. We look for the RNA itself. So how to confirm? Once there is an antibody positive patient comes to us, we have to perform the HCV RNA, quantitative or qualitative. I directly do a quantitative analysis because we should know the quantitative analysis, we should know the levels also. Sometimes in difficult cases, we have a partial response. So we should know how much it has come down. So we should always better try to do a quantitative analysis of the hepatitis C. It's better. So when it is HCV detected, then we put it as HCV infection. Suppose antibody positive, HCV RNA is not detected. That means it is a false positive test. So it means that there is no infection. So who should be treated? All those individuals with hepatitis C viremia needs treatment. And all patients more than 18 years with detectable HCV RNA should be treated. Why 18 years? Because actually all these antiviral drugs, the safety is not known till now in children. Less than 12 years, we are still we don't have good studies to say that this is safe in children, but after 12 years, it can be safely given. So that's why we wait for some time in treating the children. And then regarding the duration of treatment, how much to give, that depends on the liver condition actually. So either the patient has a cirrhosis or non-cirrhotic in the chronic hepatitis stage, and then presence of decompensation, and then whether we are treating already a treated patient, that means the patient has been treated previously with interferons or other antiviral drugs, then we have to be careful in selecting the drugs. So these are the 3 parameters on which the duration and the selection of drug depends. So how to assess the liver stage, that is liver fibrosis? Now we have some non-invasive tests to diagnose this liver fibrosis. And also we should assess for any comorbidities because we should know the renal parameters, pregnancy, associated HIV co-infection, because again the treatment duration and the selection of drugs differs. And any concomitant medications, especially anti-epileptics, simple PPIs also, when we give anti-DIA, we should be very careful in dosing the patient, right? And the presence of extrahepatic manifestations. Some people have kidney disease also with hepatitis B and C. So we have to see all these parameters and then only we start the treatment. So this is the assessment of fibrosis. I think we can skip this. Yeah, just see the red statements. We have what is known as indirect test to measure the fibrosis. These are the latest indirect tests to see whether the patient has fibrosis or going into cirrhosis. That is early stage of cirrhosis. We have what is known as composite measures. That is FIB4 and APRI and fibro test. These are nothing but biochemical tests which are as a composite manner to evaluate and assess that this patient probably might be in early fibrosis. FIB4 and APRI. APRI is nothing but AST platelet ratio index. So they have some ratios. Based upon the ratios, we see that if this is more than that, then we start the treatment. That means the patient has fibrosis. And then imaging is there. If it is there, ultrasound to detect simple cirrhosis. And some specialized tests. That is, sometimes we might need to do an endoscopy to see whether there is any portal hypertension. And now we have this elastography, the fibroscan. It is a non-invasive test to diagnose early fibrosis in the liver, right? So we use this test to see whether there is early cirrhosis or not. So this is the same thing, just I'm talking about FIB4 has AH, AST, ALT platelets and ASTN platelets for APRI. These are very simple tests and are being done in our control program. The other tests are very difficult and very costly. These are done at only research areas. But for routine, our practice, APRI and FIB4 is enough to suggest there is early cirrhosis. So these are age-old classifications for cirrhosis, in which stage it is, that is CTP, and there is a model for end-stage liver disease which has bilirubin, prothrombin time and serum creatinine, okay? And I think before we summarize, these are the things which we want to know before we start. Whether there is cirrhosis, whether there is decompensation, and then regarding the lab, hemogram, LFT, creatinine, and fibrosis, the non-invasive fibrosis assessment. If available, fibroscan or sometimes endoscopy and HCV-RNA. So as a rule, DAS are nothing but directly acting antiviral drugs. They are recommended first-line treatment in India, and the combination of the DAS and the duration of treatment will depend on presence or absence of cirrhosis. So just once the patient has anti-HCV positive, HCV-RNA and more than 18 years, we look for cirrhosis. That is with APRI. If there is no cirrhosis, the main drugs that are used are combination of sofosbuvir and daclitosvir for 12 weeks. And if there is cirrhosis and compensated, sofosbuvir and valproatovir, and if there is decompensation, then we add ribavirin, the third drug. So this is the main drugs which we are now giving in our control program. All these drugs are available, and initially this treatment, when we are treating the patient 5 years ago, we are seeing about the genotype, everything. Now we have a drug what is known as valproatovir, which can be given across all the genotypes. So now we are not testing for genotypes, that's why. So we are just giving sofosbuvir and valproatovir. And even daclitosvir is available in KGH. So we are giving these drugs, and we have very good response for all these drugs. This is the same thing. So when do you stop? What is the outcome? So we see for virological response at 12 weeks, that is known as SVR12. And when do we stop? After 12 weeks, usually we stop. We do a HCV-RNA and then we stop the drugs. But for cirrhosis, either we do a HCV-RNA and again give it for 3 months if you are not able to give ribavirin. If you are giving only sofosbuvir and valproatovir, we have to give for 6 months. That is the protocol in our control program. So this is the overall summary of HCV. A person comes to us with HCV infection. We do the baseline investigations. Patient does not have cirrhosis. Just treat with SOF and daclitosvir for 12 weeks and then perform HCV-RNA. HCV not detected, treatment completed. At the same time, the patient has cirrhosis. We treat with SOF and valproatovir for 12 weeks. Again, test for HCV-RNA. Still it's HCV-RNA detected, then here it is written as higher center, but we treat for them with ribavirin, or sometimes then we need to treat with interferons. That depends on the response, how partial response or no response. So this is the general algorithm for hepatitis C. Next, I will go to hepatitis B. So, regarding hepatitis B, I want to talk about the fulminant acute hepatitis B. This is the only area where we treat the patients with either entecavir or tenofovir. Both are nucleotide and nucleoside analog drugs. And these drugs have been started since 2005, and we have been giving these drugs. Only thing in hepatitis B is that we still can control the disease. We are not able to cure. Still, we are controlling the disease. We are suppressing the virus levels to such a stage so that the patient cannot develop cirrhosis and liver cancer. But as a clinician, we must understand that hepatitis B is a carcinogenic virus. Sometimes, irrespective of our treatment also, people land in liver cancer. That is the bad thing about this virus. This is a carcinogenic virus. So, we try to treat this patient early. Lot of studies have come from Taiwan in 2002 where they showed that proper vaccination and proper antiviral treatment, they could reduce the hepatocellular cancer reduction by 20%, 20 times. So that is where actually this vaccination strategy has come into the world. So we have now, the good thing is we have a good vaccination for hepatitis B. Though we don't have very good drugs for hepatitis B, but vaccination is there. So that is the good part of it. So what do you mean by fulminant hepatic failure? Simple, patient develops jaundice, lands in comatose state within 1 week. So this is fulminant hepatitis. For these patients only, we need to give treatment. Otherwise, usually we don't give any antiviral treatment for hepatitis B. So just keep an eye on this whole chart. This is a simple thing, but very useful. Recommended by WHO. So we screen the population, HBsAg positive, negative. And then negative, no treatment. Positive, again, like hepatitis C, we see for cirrhosis, no cirrhosis. Based on APRI test or ultrasound to detect cirrhosis. And then we do ALT and HBV DNA. But for cirrhosis, once there is cirrhosis, irrespective of DNA levels or ALT levels, all the patients need treatment. So we have to give treatment for all those patients of cirrhosis. Once they are diagnosed with cirrhosis, for hepatitis B, we have to treat them. Then comes the non-cirrhotic people, that is in chronic infected stages with or without hepatitis. Once the patient has a non-cirrhotic stage, we do ALT. ALT is persistently elevated. Then definitely we do a DNA levels, HBV DNA. If it is more than 20,000, definitely we have to treat this patient. That means these patients land in cirrhosis and HCC. That's why we have to treat this patient. Less than 20,000, again we have to wait. And then what about normal ALT? We just wait. And if the DNA is less than 2,000, usually we don't do anything. Right? So ALT more than 1.5 times, HBV DNA more than 20,000 international units, we treat. Less than 20,000, you have to wait again because these are the patients, sometimes they can come back. And at the same time, normal ALT and more than 2,000 international units, again we have to wait here because we are not sure whether these patients will be really needing the treatment. That's why we defer the treatment for 6 months in these patients. So most of the patients, if you remember, HBsAg positive, ALT is normal and HBV DNA less than 2,000. Most of the 80% of the patients will be in this stage only. They are the patients whom we tell us it's a chronic infection but without hepatitis. So they don't need treatment. So 80 to 85% of hepatitis B in the latent stage, they don't need treatment. And these are the patients who come to us with E antigen negative, that is mutated virus but with very low inflammation. So a little word about all this, what is normal ALT? So Usually we take it as 40. For all the labs, we take it as 40. And for men, it is 30 and 19. These are the changed guidelines. What happened is this ALT and business came like, we don't know about this fatty livers before. When we are doing studies, when we are assessing the patients for what is a normal ALT, at that time, we don't know about this fatty liver. So all the fatty liver patients, cryptogenic infection patients, we are not taking into account. So at that time, for standardization, it was taken as 40. After some time, when we came to know about this cryptogenic infections and then fatty livers, then we thought probably these fatty livers also are causing inflammation, and probably the ALT and AST should be much lower than this, the normal has to be. So regarding this, American Association takes as 23 for male and 19 for females. But for all public activity, we take it as 40 only. Right? What is persistently active, elevated ALT? 3 ALT determinations above the upper limit of normal in a period of 6 to 12 months. Say. Then only we take them for treatment. So once we start the treatment with drugs, we have to take care of the patient as well as the effect of the drugs, and also at the same time we have to monitor whether the chance of HCC is there or not. So that's why even after we start the drugs, we have to monitor these things. At the baseline, we have to do all those tests, ALT, HPV DNA, HBV, and all the non-invasive tests. At 12 months, again, all the tests. But ultrasound is common for all those things. Here we are seeing the ultrasound for development of HCC. So for HCC, we need to do an ultrasound for every 6 months. And alpha-fetoprotein, some of the guidelines agree, some of the guidelines don't agree, but for viral hepatitis control program, we take an ultrasound and also alpha-fetoprotein. This is how we monitor once we start the drugs. So how to treat? What are the drugs available? So just keep an eye on the adults population. We have so many drugs, but in the last 10 years, these are the main drugs. That is tenofovir and entecavir. And tenofovir has been used in HIV for a long time with good safety profile. So it has given in 300 milligrams once daily. Entecavir at 0.5 milligrams. Both these drugs are available and being given in our hospital. And let me talk about the logistics actually. When we are starting, at 10 years before, these drugs were costing 5,000 per month for the patient. Now it came down to 3,000. Now we are giving it freely. Just see the cost burden, how it has decreased. And entecavir with cirrhosis, 1 milligram. And tenofovir is the latest edition. It's a just tenofovir with some altered mechanism where it can be safely given in kidney patients also. Tenofovir, alafenamide, fumarate. So these are the main 2 drugs which were now being utilized. But I think my seniors would have remembered that lamivudine, telbuvudine, all these drugs were there. But the problem with those drugs was they have high resistance. So these drugs have very low resistance patterns. So we need these kind of drugs in a population which has low resistance patterns so that it can be given easily for all the population. So these are the basic drugs which are giving right now in our KGS, in the control program. Choice of drugs, right? Usually it's always better to start if there is no other comorbids or no cirrhosis. It's better to start with tenofovir because if there is a resistance, if there is an intolerance, at least we can change to entecavir. Don't start with entecavir. So tenofovir is recommended, right? And in women of childbearing age, entecavir is not to be given. There are no hard studies to say it is safe. Tenofovir is a drug of choice for pregnancy. Lot of studies are there in HIV. From the HIV studies, they contemplated this. So we give in pregnancy, tenofovir is the choice of drug. And when we come to the entecavir, it can be given even in children, safe when compared with tenofovir. And whenever there is a tenofovir resistance or any problem with the tenofovir usage, like bone density, then entecavir is given, right? So this is the same thing. It can be given in old ages, it can be given in younger ages, safe. Patient who are on hemodialysis and already patient has a lot of osteoporosis. Entecavir is a choice of drug. And it's safe, just one pill a day, it can be given. And the other drug is tenofovir alafenamide. This is also can be given where entecavir is contraindicated and the patient has a bad renal profile and a bone disease. There, this drug is useful. And as I was telling, other drugs which has very low barrier to resistance like lamivudine, edufovir or telbudin, they are not available and we don't recommend them as they lead to drug resistance. So this is the part of managing hepatitis B, but a lot of things are there. How long to give? Right now, we have to give it lifelong, mostly in hepatitis B, because we are only controlling the disease. We are not curing the disease. That is the problem with hepatitis B. For cirrhosis, it is a lifelong process. And can we stop these drugs at any point? So the patient has normal ALT, normal DNA levels after using the drugs for 2 years or 3 years. Yes. After 6 years, we can try this. We can try to stop these drugs based on these things. If you are very sure that within the 2 testing, within 1 year, suppose 2 tests are normal, ALT is normal, HBV DNA normal, we can try stopping these drugs. But at your own risk, because sometimes the comeback is very bad. They develop severe hepatic failure sometimes. We have seen these patients because from 2008 to 2018, our department has done entecavir study, the original study, and we had 100 patients. All were controlled well. After 8 years, we tried to stop them. And out of 100, 5 people developed severe fulminant hepatitis and they died. So that is a big problem on stoppage of entecavir, any antiviral drugs with this hepatitis B. So we have to be little careful when we want to stop these drugs. So right for now, I advise from WHO or any American guidelines also, they tell you have to give it for lifelong till now. Probably in the next future, we are expecting a good drug where we can cure the disease. A lot of drugs are coming in the pipeline, but till now, for our control program, this is the strategy which we are using. I think we can skip HBV. It's a lot of The last thing is patients with acute hepatitis B usually don't need treatment. In patients with chronic hepatitis B, try to identify whether the patient has chronic HBV infection or cirrhosis. Again, in cirrhosis, whether it is compensated or decompensated. So all those with cirrhosis, they need treatment. With chronic HBV and no cirrhosis, the decision is individualized. And when there is co-infections like HCV, HIV, the treatment is little different. I'm not focusing right now. And the treatment is little different. Right, thank you. And